members, and you might be able to say whether the slides would be loaded into the harvester. I know CMS, I know, but they would be happy for us to do that.
Okay.
At whatever time.
Good afternoon, everybody. Sorry about that. We definitely have audio now. Thank you so much for joining us today. For those of you live in the room, we obviously have an overflow crowd, and we will do everything we can to get a few more chairs in, so you won't be sitting for an almost a full hour. We are a few minutes late getting started. I'll introduce myself. My name is Bryn Barnett. I'm the Alliance Director of Communications and Public Affairs. Jacob Coverstone is a member of our Coalition for CEHP board, and he is your host and moderator for the day. Also joining us on the phone, as you know, is Anita Greiner. She is with the CMS office, that's the Centers for Medicare and Medicare Services office that oversees the open payments implementation from the regulatory standpoint. So without further ado, I'm going to give some time here to Jacob, if he would like to say a couple of words.
More logistics than anything else, but first, welcome everybody. This is an impressive turnout, so thank you all for coming. We're really happy to be able to bring this from the Coalition of the Alliance. It's the third now webinar. We are broadcasting this as well, and I think we've had about 200 people sign up there. We're going to be getting text questions in through the webinar, and they should hopefully be able to hear me now. And we will have people in the room able to ask questions via microphone to myself and to Anita at CMS. So we're going to get going in just a minute here. That we're going to do a brief intro, and this is mostly Q&A time. We're not going to spend a lot of time dwelling on things or covering the same FAQs that are already up on the CMS website. It's a great resource. Check it out for sure. Hopefully all of you have at least some exposure to the sunshine rules. If not, in the conference harvester, you can find the entire final rule. And I think we're going to get going here. Oh, or Bryn's got her hand up.
Oh, no, sorry, I was
all right, if that's
multitasking.
If everything's going well, we're going to have
Yes,
Anita?
Before we turn it over to Anita, I just do want to remind everyone who is bearing with us on the webinar. We've got almost 150 people online, and it is wonderful to say that this is the first time we are broadcasting live from the Alliance Annual Conference, so it's very exciting for us. But if you are online and you would like to ask a question, just a reminder that you can type that in your chat box, and we will get to as many questions on the webinar as well as in the audience here live as we can. So. With that, I will turn it over to Anita if you would like to say a few words, and then we can begin with your slide presentation.
Hi, thank you so much, everyone, for the introduction. My name is Anita Greiner, and I'm with the Centers for Medicare and Medicaid Services in the Center for Program Integrity. I'm the director of the Data Sharing and Partnership Group here at CMS, and our role in the Open Payments Program is to implement the regulation, including the supporting IT systems and the public website where all of this information will, of course, end up this fall. And so our team is essentially responsible for implementing, operationalizing this program. So we're really glad to be here today. We try to engage and communicate about this program with stakeholders as much as we possibly can because it is a new program. There are a lot of areas where we have questions coming in, and we want to make sure that we are as clear as we can be. So thanks for having us and giving us this opportunity to talk to you today. So I do have some slides that we're going to walk through here, and I do know the majority of our time will be spent for Q&A, so I'll just briefly walk through these slides. So we're starting out here on slide 3, correct? Okay. So overall objectives of this program, Open Payments is a national level transparency program which will take information regarding transfers of value between manufacturers and group purchasing organizations and physicians and teaching hospitals and make this information publicly available. So at its core, this is a national transparency program. The two main objectives of this program are to make financial relationships transparent and publicly available on a national scale, again, transfers between the industry and physicians and teaching hospitals, and giving consumers more information by which they can use and make informed decisions, have dialogue, and discourse with their physicians about this information, essentially allowing consumers access to another level of information regarding their healthcare professionals. CMS's role in this program, as mentioned, obviously, is to implement the regulation, but it is very critical and part of our approach to remain neutral with regards to any interpretation or presentation of this information on the public website. We will make this information publicly available. We will not be in the business of drawing judgment about appropriateness or not of the specific transfers of value. We must ensure that the reporting and disclosures on the public website are complete, that they are accurate, and that they are very clear to the public at large about what is this information that they are seeing on this National Transparency website. So moving on to slide 4. These financial relationships that exist today between industry and physicians and teaching hospitals, they run very deep, they're very pervasive, and they exist for numerous reasons. There are a lot of very, very beneficial reasons for financial relationships to exist between industry and physicians and teaching hospitals. It promotes the discovery and development of new technologies and innovations, helps to identify advances in healthcare via research and other very important areas such as education. However, there are occasions where financial relationships between industry and these healthcare professionals may create or increase any potential conflicts of interest. And so the balancing of these two areas is really important, and this transparency program, again, won't draw judgment upon appropriateness or not of the transfer of value. We will simply be making this information publicly available. Slide 5. So this specific regulation was part of the Affordable Care Act, specifically Section 6002. The final rule did publish on February 8th after about a year and a half of rulemaking from the NPRM stage, which published at the end of 2011. We did receive several hundred comments during the rulemaking process, which we made careful attempts to incorporate into the final rule as appropriate. But it did publish on February 8th of 2013. Slide 6. The high-level program requirements for open payments, Section 6002 of the Affordable Care Act, requires that manufacturers of covered drugs and entities under common ownership with those applicable manufacturers report to CMS annually regarding payments or other transfers of value that they make to covered recipients and physician owners or investors, as well as reporting certain ownership and investment interests that are held by physician owners or their immediate family members. In addition, additional applicable group purchasing organizations are also required to annually report to CMS certain ownership or investment interests held by physician owners or investors and their immediate family members. And for those owners or investors, they also will report payments and other transfers of value that were made to those physician owners or investors. Slide 7 discusses one facet of covered recipients, which are the physicians. These are physicians, doctors of medicine and osteopathy, dental surgery and dental medicine, podiatric medicine, optometry, and also licensed chiropractors. They must be legally authorized by their state to practice in order to be considered a covered recipient. A couple of notes, fellows are included in the definition of covered recipients, as well as physicians who may not have any other relationship with CMS. For example, a doctor of medicine, an MD, may not be enrolled in Medicare or provide services to Medicaid. However, if they are a licensed doctor of medicine, they would be subject to reporting, irrespective of having a relationship with CMS as a Medicare enrolled physician. Medical residents are excluded from the definition of physician. On slide 8, in addition to physicians, teaching hospitals are also subject to reporting. And the definition for the teaching hospitals are hospitals that CMS has recorded as receiving a payment under either Medicare graduate medical education, GME, indirect medical education, IME, or psychiatric hospital IME programs. And we have compiled and will continue to list on our website those teaching hospital entities that are subject to reporting. So we have issued the list for 2013 prior to data collection beginning, and the list for 2014 as well. Industry has been instructed for the 2013 program cycle. They will be collecting and reporting using the teaching hospital's legal business name and report data separately for the legal business name, the taxpayer identification number or TIN, and address combinations that we have included on our list. We have provided industry with a supplement to to the 2013 list to ensure that the applicable manufacturers and applicable GPOs are also aware of the various institutions owned or operated by the legal entity so that they can collect the appropriate data. This was actually in response to various inquiries that we received where they were seeking a little bit of extra guidance on the teaching hospital list. So we have provided and afforded industry with that supplement. Slide 9 discusses the physician owners or investors and their immediate family members. There is a list here that describes what is considered immediate family members, including spouse, natural or adoptive parents, child or siblings, step-parents, step-children, step-brothers, step-sisters, fathers, mothers, daughters, and so on, grandparents, grandchildren, and spouses of those grandparents and grandchildren are considered immediate family members and subject to reporting under the Open Payments Regulation. Slide 10 discusses the different types of payments. Two big categories are direct and indirect payments. Direct payments are those payments that are between an industry and the physician, for example, which are paid directly to the physician or teaching hospital. Indirect payments are payments that are made to the physician or teaching hospital through another source. For example, if it went from a medical association to a physician, that would be considered an indirect payment. We also will be collecting information on payments that are designated by a physician or teaching hospital to be paid to another party. So those are considered third-party payments. So the payment goes from the industry manufacturer to the physician, and the physician routes or directs the industry company to actually make the check payable to someone else, for example. Those are considered third-party payments. Slide 11 discusses one exclusion of reporting. So there are particular continuing medical education, continuing education events that are not subject to reporting if they meet these 3 specific criteria. The program must meet the accreditation or certification requirements and standards of 5 named organizations that are listed here, including ACCME, AOA, AMA, AAFP, or ADA CERP. Second criteria is that the manufacturer does not directly pay the physician speaker. And the third criteria is that the manufacturer does not select the physician speaker or provide the third-party vendor with a distinct identifiable set of individuals to be considered as speakers. So the accreditation standards, not making direct payments to the physician speaker, and not pre-selecting or providing a predetermined list of who the speaker should be. If those 3 criteria are all met, then that particular event is not subject to reporting. On slide 12, there are some timeline and milestones of note. This is specific to the 2013 data collection year, and the data collection period started on August 1st of 2013 and extended for 5 months through the end of 2013. This was when industry was tracking the payments and transfers of value that they made to industry. And then starting in early 2014, we will open up our open payment system for registration for the industry to come in and register with our system and also upload the appropriate data from 2013 data collection into our system. Physicians and teaching hospitals will then be afforded a 45-day window where they can come in and review the information that was submitted about them across all of the applicable manufacturers and GPOs. At that time, physicians and teaching hospitals are also able to file disputes about information that they feel is inaccurate or incomplete or missing. Those disputes will then be routed back to the appropriate manufacturer for correction. So after the 45-day window for physician and teaching hospitals to review their information, there will be an additional 15 days afforded to the industry to make any final updates to the data to correct any disputes. September 30th of 2014 is when the data will be made available to the public for the first time. So that is a very high-level overview for you all about the program requirements and the timelines coming up for this next year. And I believe now we are going to